minimally cardiac surgery his life. He's a senior clinical perfusionist in Brighton, Sussex University, from the NHS Hospitals in England. So is he with us online? Dr. Vieira?
Yes, can you hear me? I'm gonna just share
Thank
my.
you very much. Hi, thanks for being with us.
My pleasure. Okay, my senior perfusionist here in the UK, the United Kingdom, in the Royal Sussex County Hospital, and I'm going to talk about our experience here using the custodial, and I'm going to give you a bit of the insight from a perfusionist with a few tips and comments that I ought to be useful for this arena. Can you see my screen well? The custodial is, we have been using custodial as a solution for myocardial protection, and just the key principles of action for any cardioplegic solution, we should have in mind in general lines two things. One is minimizing energy requirement of the organ for the duration of the ischemia, inactivating the cell, and secondly, optimizing the anaerobic energy production for the duration of the ischemia. So we can do this artificially buffering the organ. So specifically with the custodial, we have several kinds of cardioplegia for myocardial protection, and the custodial is in the category of intracellular crystalloid solution. Why they call intracellular? Because of the low electrolyte levels of sodium and calcium. So there are two mechanisms of the arrest of the heart using this cardioplegia. The first one is the sodium depletion in the extracellular space, so resulting in the hyperpolarization for the myocyte plasma membrane, so inducing the cardiac arrest in diastole. Also, the low extracellular calcium solution, the custodial solution, arrests the heart in diastole by inhibiting the excitation contraction coupling. So the custodial is a different solution. Like we used all over the world the St. Thomas cardioplegia, that is we change, it plays in different mechanisms of arrest. We call the depolarizing arrest extracellular solutions. So custodial also we have the histidine that acts as a buffer in the scavenger, and you have also the tryptophan that stabilizes the cell membrane, and the ketoglutarate that supplies energy substrates. So that's the main components of the custodial cardioplegia. You have also mannitol that also works as a scavenger. So this custodial here in UK has been approved for specifically for cardioplegia in myocardial in cardiac surgery operations in 2022. Here in our institution, our hospital, before we haven't simply bought the cardioplegia from the supplier and start using. This process has involved our perfusion department, has involved the anesthesia department, the surgeon, the lead cardiac surgeon, the pharmacy manager, and the medicines governance committee. So it wasn't simply just buying the solution and start using straight away. So we went through several processes in our hospital involving a multidisciplinary team, approvals, and establishing guidelines and protocols. So our experience here in Brighton, we started using these since May of 2007 in the minimally invasive mitral valve surgery program. And we know, and it has been proved that this solution is an effective and safe, as well convenient, because of the single dose method. So in minimally invasive mitral valve surgery, so the early stages of the learning curve is we have the cross clamp times, higher cross clamp times. So we wanted to change this standard approach of a high strength potassium plegia with the St. Thomas plegia that you have to re-administer every 20 minutes, 25 minutes or so. So you know, as a surgeon, it's releasing the atrial retraction in the minimally invasive cardiac surgery is very disruptive and time consuming. So you have to release the atrial retractor, otherwise the aortic valve would be distorted and the plegia wouldn't go to the left ventricle. So all these processes are time consuming. You could imagine this in a very small hole. So we started shifting now towards this cardioplegia, this type of myocardial protection. So we went for formal visits in various experienced centers here in the UK and abroad. In the beginning of the custodial, I'm talking about a bit of our learning curve. In the beginning of this, the usage of this strategy for myocardial protection, we had a patient group selection with no aortic valve regurgitation in normal coronaries. And I can talk about a bit more about why this kind of cohort of patients. We started not immediately in the minimally invasive cardiac surgery. We just using as a full sternotomy approach in elective patients. Very important adherence to of the institutional protocols, so that we established before, according to that slide that I mentioned before. And with that, we gain confidence and experience, and we start to advance these to complex cardiac surgeries, combined valve procedures, complex aortic, like frozen elephant trunks and redos and so on. In our practice, I'm going to specifically as a clinical perfusionist here, we have some reference values. So the induction and the subsequent delivery time of those time of dysplegia is critical. So we have 2 liters of about 6 to 8 minutes. So it's a completely different kind of cardioplegia when the surgeon will expect a very rapid diastolic arrest using potassium, as we've been using. This cardioplegia is different. So time is the essence, because we're going to be displacing the blood from the coronaries, and the pressure is much lower in this cardioplegia. It's not a blood cardioplegia, it's just pure clear fluid crystalloid plegia. So the reason for that, we ensure the homogeneous distribution and equilibration across the extracellular space in this tissue. And in addition to that, we're going to ensure the cooling of the myocardium. So this time should never be cut short. So the surgeon put a cross clamp and take it and relax 6 to 8 minutes and wait the patient to act. So the temperature of this solution is delivered around 3 to 6 degrees Celsius. The initial dose is 20 ml per kilo, and maximum of 2 liters. So normally you're gonna see values around 1,500 to 2 liters. This 3.5 liters is unusual. It's just in case we have some adversities like leaks and so on. But the dose of dysplasia is 20 ml per kilo, the initial dose. The subsequent dose is just half of the first dose, is 10 ml per kilo. So give a liter of dysplasia if you need to give replete the heart. Antegrade delivery, we have a few specificities with this quadriplegia. So we not measuring the aortic root pressure. You know, the aortic root pressure is something around 55, 60 millimeters of mercury. We're measuring here the cardioplegia line pressure. So normally we will get around 150 millimeters of mercury. This is these are information, very specific information from the perfusionist view. So after the electrical arrest of the heart, so why do we give this initial burst, fast burst? Because we want the aortic valve to close. So after the arrest of the heart will arrest normally between 300 ml to 700 ml of dysplasia. So we reduce the line, the flow, and consequently the pressure of the line to maintain something around 70 millimeters of mercury to the remainder of the dose until we complete the dose. So we're gonna time it properly to last up to 80 minutes. Maintenance of the dosage. The perfusionist will notify the surgeon. Here in our centers, we know that this kind of quadriplegia we can use for up to 3 hours with just one dose. Here established, and it has been safe and effective. After 90 minutes, we just let the surgeon know. So the surgeon can relax doing his loop repairs or in the mitral valve up to 90 minutes, and I'm not going to disturb the surgeon. So from this point, he can have in mind that you may give a subsequent dose or not. So we've been doing this using dysplasia around 120 minutes without redosing and working absolutely fine, effective with any other problems. So the subsequent dose should be given in this case if the electrical or mechanical activity is evident. So if you need a redose, we will give redose dysplasia. Some technicalities, some tips here, the custodial. So I've seen our noble colleague anesthetist in the beginning mentioning the importance of the TOE, the transesophageal echocardiogram. So that's it's paramount during this arena. Why? Because they're going to inspect the LV. So if you're giving this quadriplegia, and that therefore cohort is very important to this patient doesn't have any aortic incompetence. Otherwise, dysplasia would distend the LV and it will be defeating the object. So very important for the use of custodial in minimitals competent LV. So during the induction of this quadriplegia, the anesthetist will be assessing the TOE and having a very close look in the LV to avoid or to pick in time any distension. Again, the clamp there's obvious information, but the clamp aortic cross clamp should be properly placed. If doing redos, the lima should be clamped because this quadriplegia is very sensitive to washout. These quadriplegia line pressures are very, very low because, as I mentioned before, there's a very low viscosity and the high pressures would cause myocardial edema. So the aortic root pressure is not measured. Bear in mind, you don't measure the aortic root pressure in the DLP cannula. You're measuring just the cardioplegia line pressures, and these will be essentially around 75 millimeters of mercury. Obviously, the cardioplegia line pressures, the rate of flow of the plegia is dependent in a series of specific parameters, like diameters of the cardioplegia, tubing, wall thickness, etc., etc., etc. So we very important. This is our standard, but we can discuss this further as a perfusionist point of view. Important to the duration time of the infusion of this plegia between 6 to 8 minutes. Again, aortic root, the TOE, we, as I mentioned before, we're going to observe the arrest of the heart around 300 to 700, after 300 or 700 mL of the infusion of this plegia, approximately 2 minutes, the heart will arrest, and from that point, the perfusion will time to last about 80 minutes. So a very quick maths, 250 mL per minute will take 80 minutes. It will give you normally two bags of liters of this cardioplegia. 20 mL per kilo is the recommended initial dosage. But if the patient, for example, weighs 80 kilos, so in theory, we would give 1,600 mL or 1.6 mL of cardioplegia, but it will extend for 2 liters for the 2 full bags of the cardioplegia. Obviously, if you're giving this cardioplegia, this is in the aortic root, and we will give the cardioplegia in aortic root based on aortic valve competence. In case of, as I've mentioned before, we extended for more complex cases. If you need to give this cardioplegia to the ostia, we also have to adjust the flows and pressures according to the small osteocannulas. But this would take, again, aiming for 8 to 10 minutes of delivery. In other exceptional circumstances, you may need to give this cardioplegia custodial through the retrogradely, through the coronary sinus, and again, note that if you're giving this cardioplegia through the coronary sinus, the right ventricle might be unprotected, so we may need to make sure we're going to give this antegraded right coronary ostia. We can observe a few flows around 250 mL per minute in the coronary sinus. Importantly, this cardioplegia is 2 liters of crystalloids. You're going to note, in order to mitigate the hemodilution of the patients, you use a hemofiltration, and you add a bit of, with that, concomitantly, you use a liter of saline, 0.9%, and you add 8.4 50 mL of sodium bicarbonate, 84% into this bag, and you just drip very slowly. So hyponatremia is not a big issue for you. You run operation adults, and you're going to see normal sodium after the administration of the plegia around 112 or 120 millimole. But by the time we corrected the hemofiltration and add the sodium, these values come back to normal by the time we're ending the cardiopulmonary bypass. And again, so normal plegia scenarios, electromechanical activity and custodial is not different. So if custodial is very sensitive to washout, so if you have high non-collateral blood flow, exaggerated left bronchial venous return, it may wash out, so you may need to replege again. Obviously, insufficient aortic cross clamp, venting of the LV. I would recommend using the vacuum assisted constant venous drainage, VAVD. Why? To keep the right side of the heart empty, avoiding washout of dysplasia. It's very common to observe some sort of ventricular activity around 20 to 30 minutes of elapsed cross-clamp time, but this will disappear without repleting again. I would suggest, and we've been using frequently, and the topical slush, that ice in the heart, of observing, of course, the necessary care for phrenic injuries and so on. Obviously, the perfusion is not going to infuse blood into the coronaries in the circuit, because this would wash the plegia out. So to reverse this cardioplegia, we just reopen the aorta, and myocardium will be flaccid, and we can keep these lower pressures, and after 2 minutes we can increase the pressures. If you have persistent ventricular fibrillation, we have to look TOE for diagnosis. Again, TOE for intramyocardial coronary gas, graft kinking, spasm, and so on and so on. And in the case of the mitral valve surgery, look at the circumflex artery to see if any stitch has been caused any lesion or stenosis in these coronaries. Keep the heart vented, avoid distensions. We can give a few shocks, maximum to 6. Then I was talking to an anesthetist yesterday. He just really considered giving lidocaine before the cross-clamp release, lingocaine. You can give also amiodarone in the pump in case of persistence of ventricular fibrillation. If there was no heart mechanical activity or electrical activity during the case, this is a good indication the cardioplegia has been working fine. And finally, we can say that the cardioplegia we use as a single dose administration, and we extend the period of myocardial protection. Is effective, is safe, it's convenient for these complex procedures. It's less disruptive of the surgical flow, and we have increased surgical efficiency. I mean, the scope of these slides here is just not to talk about the length of stay, the length of stay in the ICU, etc., etc. It's just to just give you a very quick information, brief information about our experience here. Thank you very much.
Thank you very much. Congratulations. I think it's a great journey to follow on the cardioplegia substances. Give my greetings to Ishtak, who's a good friend from our training years. It's very interesting that most of the centers that use minimal invasive practice had to move from the blood cardioplegia. Have you had any experience with the Del Nido cardioplegia, which is what we found in our small journey to be a good compromise between the two?
Del Nido, we haven't used Del Nido yet, but I know I met him 2 or 3 times in New York in previous meetings, but we haven't used. I think it's a very interesting concept as well, Del Nido, because of the we use in Del Nido have blood is in a 1:4 ratio. I think there is a lot of space for Del Nido as well. I think custodial and Del Nido, they work together. And I think certainly there is a good use for Del Nido. I don't have any experience.
Thank you. Thank you very much. I think we'll hear the comments from Dr. Aristotelis Panos, who's a cardiac surgeon at the clinic of Athens Medical Center, and he's associated with the University Hospital Geneva, where he's been an associate professor and a lot of experience with minimal invasive.
Thank you for inviting me. Thank you, Dr. Mr. Vieira, for your extensive topic on this kind of cardioplegia. As I'm using cardioplegia custodial through more than 70 years now, I think is a good cardioplegia. And you had Dr. Pereas asked before for the comparison between Del Nido and Custodiol. I would add that Del Nido is also a good option, but for shorter procedures, and but does less hyponatremia, which is much less, hemodilution, which for some patients must be of good help. Now, concerning the protocol of giving Custodiol, we share the same protocol as you do. And we haven't had any particular problem. Usually at 90 minutes, if the procedure has to go longer, I do standard second dose with the same volumes. And finally, for the Custodiol, I can say that we have to monitor all the way through the whole way of CPB, the electrolytes, which is very important to have a very correct equilibrium of natrium and also the calcium. But we do not have to give early calcium before having a real hypocalcemia, because this acts and negate the effect of the cardioplegia on the myocyte. Otherwise, some studies, actually many studies, have compared head-to-head these cardioplegias between Del Nido and Custodiol, except for the duration. Otherwise, they are quite equivalent on the protection of the myocardium. And just for information, in Basel, years ago, in the early 2000s, they had developed a new cardioplegia, more for minimally CPB for the coronaries, which is the Cardioplexol, which is with 100 milliliters only dose, that gives quite a good protection for small procedures around 1 hour. And this contains potassium, magnesium, xylitol, and 5 milliliters of procaine. And is one shot very quickly, and is given by the surgeon directly in the aortic root. Thank you.
Thank you very much, sir. Any comments from our perfusionists? Because it would be nice to engage in a conversation for a few minutes. You've seen cardioplegias. I don't know, most hospitals are using most of them. Like we've been through more or less everything. Dimitris, would you like to make a comment? What is your perception on, because this is a very important issue, and we all have, there were experiments from Backberg and Buxton in the past, but
yes,
now we don't have a lot of information.
Thank you. My name is Dimitris Poulis. I'm perfusionist at Onassis Cardiac Surgery. I work also with Dr. Pereas. Yes, we at the last 2 or 3 years, we have changed from the Custodiol to Del Nido with excellent results. Of course, Custodiol we used at the cardiac surgery for many, many years, so there is no any questions on any doubts about the value of Custodiol. But also the results of Del Nido is excellent. We don't have a hyponatremia, we don't have a big hemodilutions, and also we keep with the Del Nido, we keep the osmotic pressure in a very normal range. So we suggest the use of Del Nido instead of Custodiol. Thank you.
Thank you very much. Please.
Can I ask you, what do you believe is the safe cross-clamp time for Del Nido cardioplegia, and what time do you give an additional dose, and how much?
We have seen a very good cell protection of the myocardial for up of 90 minutes. Sometimes we have above 90 minutes, but for 100 and 110 minutes, we have excellent results. Okay, very good protections, and immediately after the cross clamp, we have immediately a cardiac rhythm without VF.
Yes. This is anecdotal, what Dimitris is saying. I've read it in papers too, because I was very, very much accustomed to the St. Thomas's in UK and then to HTK, which is slightly more expensive too. There's a lot of issues that make the decision.
I don't make any comments about the cost.
It's not the cost, but what I have seen frequently, even though we still use it in the transplants and the very long-lasting surgeries, the RV, this is anecdotal, and I welcome any comments. The right ventricle was always slightly more tired in the end of an HTK perfusion. That was my anecdotal impression with a few hundred of cases, not just a couple. And also what Dimitris is saying, when we open the cross clamp with Del Nido, most of the time it takes less than a few seconds to get back into a rhythm, while with HTK, like Mr. Vieira mentioned, very frequently, I do remember a few minutes of VF going back, starting back and forward. And I think he touched on all the important issues. With HTK, you have to be 100% sure there's no flashing of the coronaries. The cellular space as well as the coronaries have to be filled with this solution, because otherwise coronary blood flow can gradually decrease the protection of the heart. And if you add to that the possible RV dilatation that sometimes occurs during our minimal invasive cases, because the suction and the perfusion is not perfect, even though you guys are perfect. So these two make Del Nido sometimes, a good bailout option. That's how I felt. Anyway, thank you very much for your comments.
Okay, for Mr. Vieira, I would like to ask you if you use every time, in every case, hemofiltration with custodial, or maybe sometimes you put it on the cell saver, or maybe you suck it out.
Yes, the majority of the cases, it's just the surgeon preference. We use the hemofilter to mitigate the hemodilution, and there's no problem whatsoever. The levels of hemoglobin are back to normal. But as you mentioned, yes, more in pediatric, we don't do pediatric surgeries here. But yes, that would be an interesting idea to open the RV and suck the custodial out to the cell saver. In adult, we can mitigate this with the pretty well using the hemofilter. Yeah.
Okay, thank you.
Thanks.
Thank you.
Thank you. Professor Kofidis would like to make a comment.
Thank you very much. Very nice presentation. Now, if I'm also a Del Nido convert, I started with all kinds of cardioplegias, tried out custodial for the most part. 10 years ago, we switched to Del Nido. But the devil is in the detail. And I would just add to the very valid comments made that we personalize it for every patient. So minimal invasive bypass surgery, for example, is a routine in our program. And I feel that Del Nido doesn't work so well if you're dealing with severe ischemia. So we went back to use blood cardioplegia in ischemic cases. Now, if you run into trouble, of course, which I will refer to later, in minimal invasive mitral aortic valves, then there are escape routes. Again, there's no black and white. Del Nido is fine, but then you have different weapons in your armamentarium. Cool down further, do it on the beating heart, fibrillating heart, whatever. So there's no surgeon here with experience in minimal invasive who hasn't been in these situations before. So Del Nido, yes, in my opinion, but we're not religious about it, particularly in ischemic or suspicion of ischemia.
Thank you very much. Shall we? Yes. Dr.
Thank you very much for all these comments. From my point of view, I copied from Dr. Bakhtiari in Bonn, his protocol, just 1 liter of custodial for 60 minutes. So I prefer to do minimal mini sternotomy for AVR. So for AVR, I prefer to give just 1 liter of custodial. And if I don't want to give custodial and to give Del Nido, I think that it is the safe the safe period for Del Nido is 60 minutes. If you don't want to have any problem, you have to give custodial for 60 minutes, and after that to give more Del Nido, and after that to give another dose of Del Nido for the next 60 minutes. Thank you.
Thank you very much, Christopoulos. Okay, thank you, Mr. Vieira. Thank you very much for your contribution. Hope to see you again soon. Bye-bye.
Pleasure. You're welcome.